started here as a medical director in 1998, and part of my job was to do some kind of quality improvement. The first thing we did was, in trying to improve our diabetes care, was to look at what the standards were. And then we saw, whoa, we've got some improvement needed here. And then we disseminated the results to our doctors, who of course didn't believe it. They thought that they were doing just fine. But then they realized when the data was in front of them that, oh, there was room for improvement. We saw that we can, by paying attention to these things, we could really do a better job.
About 10 or 12 years ago, I got frustrated with the paper chart. It seemed that a great portion of the patient contact was spent trying to find things, particularly tests and things that were important or things that were several years old that had relevance to the medical problem now. So I hired my children. I have 3 girls, and they came in and organized my paper charts with files. So we spent the better part of a summer doing that, and then after all that time and effort, I realized this really was no better than what I had. So with that, we went to the electronic chart and computerized record keeping.
Afternoon.
Very well, doctor.
Good.
Typically, the schedule lightens up after September, and so we said, what could we do that would improve the schedule, bring more patients in, but at the same time improve the health of our patients? So we looked at doing a flu campaign. We wrote up a letter and said, you would be a good patient to get a flu shot, and gave some details. The program worked quite well. The patients were pleased with it, and we continue to do that year after year.
The impetus to change really came from one of my newer partners. He sort of gave me a kick in the backside and said, wake up, we can improve this. And that started us moving. He had connections with the International Diabetes Center in Minnesota, was able to bring their materials and some of their expertise to us, and managed over a period of time to bring all of us together to review standards for care, to review our own data. This is Jean, who's one of our nurse practitioners, to brainstorm on how to adapt guidelines to our local reality with our local resources. So we adapted an existing guideline and promised ourselves to act more in concert with that. And then we went on and measured how we were doing.
Easy access was an idea which came from the Institute for Healthcare Improvement, and we took that and modified it for our use. So all of these ideas were there. We look at the literature, see what's going on, try to learn from who has done this in the past, and then adapt it to our needs, see where the issues are going to be for us, which is different. Every practice is different.
There's other outside forces that are helping us sustain our quality initiatives. For example, the peer review organizations for Medicare are evaluating the care of our diabetics. And Blue Cross in the state of Florida is now starting a pay-per-performance program to help actually give bonuses to physicians who maintain certain levels of quality.
It would have been difficult to have done as much as we have without external support. We had our own program ongoing when we joined an external consortium, but emotionally it's extraordinarily valuable to have other people that are doing likewise. The ability to email somebody with a question, the ability to have a meeting where you do compare your data, where you problem solve on issues is terrifically valuable.
Sustaining the gains is a challenge, and we started with a grant-driven program that expired basically in a year. And with that went that extra person to extract information and data from records. And quite honestly, it really foundered for a little while after that. I'd say about 6 months. The information gathering then fell back to me. As medical director and someone who was interested, I decided that I would figure out a way to maintain the flow of information, at least let people know how we're doing, and have spent the last 4 or 5 years really refining that process to make it more workable and actionable.
The biggest barrier with the electronic records were the cost initially, but once you're beyond that, The ongoing process of correcting glitches is probably the most frustrating things for me. If there's a software-related issue, then I just simply have to be patient.
Anytime we've made change, we've always tried to do it on an incremental basis, try it out, see if it works, and then begin to expand it to other areas of the practice. For instance, when we did our easy access program of changing our appointments, we had just one practitioner change his schedule and watched and saw what happened over a period of weeks. And when it seemed to work, we then began to expand it to other practitioners in the practice.
We had done an audit a couple years ago to see how well we were doing for pneumococcal vaccine in seniors, and our results were about 50% of our seniors were getting pneumococcal vaccination, which actually is about the national average. But it seemed like we could certainly improve that, and so we had the medical records staff go through the charts for the next day, and as they were preparing them, identify who was over 65, and they'd put a stamp and a sticker on their chart to remind us, oh, they're over 65, check and see if they've had a pneumonia shot. We were able to show in our study that we could improve the vaccination of our patients from in the 50s to almost 80% with a simple sticker and a stamp.
The consortium that we're part of is led by the Medical University of South Carolina. They help us institute changes within the practice by way of utilizing the electronic records more efficiently, and then they provide the quality assessment on a regular basis. Some of the success that we have with coronary disease, atrial fibrillation, you expect to be good and you are. Hello, how are you? But then in other areas you find that you're not doing as well as you could or should, and so the combination of having nationally recognized standards of care, a vehicle that rates how effectively you do, puts you in the position of saying, okay, I need to do something about that.
One of the issues that we faced in improving the quality was documenting that patients had eye examinations, and this required getting a letter into the chart for diabetic patients. In order to do this, my partner wrote up a letter generically addressed to all the optometrists and ophthalmologists in town, saying this is really important part of quality care, and so that if you're treating our patients, we'd like at least a brief note saying that they've had their dilated eye exam and what your findings are. The result of that letter was that our numbers jumped up considerably, starting with about a 15% incidence of letters in the charts when we did our first run-through with the QIO. We had jumped up well into the 70s at the follow-up.
For quality improvement, leadership is critical. There's no question, because it's not going to bubble up from any one person coming up. It really has to have the stamp from the top that this is valuable, because it will mean changing how you do things, or shifting resources, or both.
Every 3 or 4 months, Dr. Balder will place in our box a sheet here that gives us my semi-annual hemoglobin A1C rates. It's just a good reminder for me, especially as I'm going through my training, to really have ingrained all those things I really need to do to take care of my patients well. And without someone checking up regularly on those things can easily fall through the cracks.
Some of the things that help us along the way, we've had some really neat and talented individuals here who have developed simple, easy-to-use materials that help.
This is a big reminder for me. It's just really kind of a checklist that can be used to keep track of the healthcare maintenance things that have been done for our diabetic patients. This is a diabetes care card. This the patient takes with them, and so they can keep track of their own progress. I think by having one of these cards, it gives patients ownership of their problem, and so they feel like it is more of their problem. And then I think if they own the problem, they're more likely to make changes.